What can you do to improve your surgical efficiency when treating angle fracture? In this lecture, we'll be covering basic concepts as well as advanced techniques that will help you achieve greater efficiency. For the discussion of this lecture, we'll assume the fractures are simple and not comminuted or segmental defects. Angle fracture involves the posterior mandible where the third molar is located. We'll start out by discussing visual reference that tells you that you have proper reduction of the angle fracture. First, you have the oblique line. You also have the posterior border of the mandible and inferior border of the mandible. So it's important to expose the full extent of the fracture until you reach the posterior border as well as the inferior border of the mandible. So what are important anatomic structures that you should aim to preserve? First is tooth roots, and we discussed that tooth roots can be assumed to be twice the height of the dental crown. This means that when you're placing a screw, you want to place them in between tooth roots, and ideally the plate should be placed inferior to the level of the tooth roots, generally inferior to the mental foramen. Now, unique to the angle fracture site, you may be dealing with the third molar. It will typically be buried unless it has erupted. The key thing to remember about the third molar is that you generally want to leave them alone unless the presence of the third molar prevents proper bony reduction, and also if the tooth root itself is broken, as it can lead to delayed harder infection. Now, the downside of removing the third molar is that it can now lead to a bone gap where the third molar used to be, and this may introduce some bone instability. So generally leave them alone unless a tooth root is broken or if the bone reduction is not possible. Another structure is the inferior alveolar nerve. The nerve itself will be traveling in this area as it goes towards the mental foramen. And typically the superior plate will come in close proximity to the nerve itself. So the key to avoid injury is to use a monocortical screws so that the screw itself will not penetrate the nerve. And along the inferior plate, it may be safe to use bicortical screws that are much longer than 4 millimeters. With that said, in practice, I'll generally prefer to use monocortical screws for both top and the bottom plate, since I don't know exactly where the nerve is traveling. I'll typically use 3 to 4 millimeter screws along the superior plate and 4 to 8 millimeter screws along the inferior plate. Another relevant structure is the masseter muscle. Masseter is located lateral to the mandibular bone, and when you're dissecting the fracture, it's essential to remain subperiosteal as you dissect towards the posterior border and the inferior border of the mandible. If you drift away from the subperiosteal tissue plane and dissect within the masseter, it'd be very hard to visualize the bone itself, and also you may cause intramuscular hematoma that may be a problem later. Another important structure is the facial nerve. Facial nerve will be transversing this area as it travels towards the lips. One of the ways to minimize injury is to perform surgery without muscle relaxant or muscle paralysis. If you happen to be in close proximity to the facial nerve and your instrument stimulates the nerve, it will cause facial twitching. This will be a visual cue letting you know that your instrument is in very close proximity to the facial nerve. There's a potential facial nerve injury when you're placing a transbuccal trocar. To minimize this risk, your facial skin incision should parallel the direction of the facial nerve and cut only through the skin itself. The skin incision should be placed at the center of the fracture site where the plate is being placed. And you should use a blunt tip instrument such as a mosquito, forceps, to dissect from the subcutaneous tissue through the masseter to reach the subperiosteal tissue plane. Another structure is the buccal fat. Buccal fat is located medial to the mandible, and it can be exposed when you're exposing along the ramus as you dissect superiorly. It's best to avoid extrusion whenever possible, and you can use to retract it with the obigator ramus retractor or a long toe-in retractor. If there's excess extrusion of buccal fat that is interfering with visualization, you can perform conservative excision if necessary. One key crucial structure to keep in mind is that buccinator branch of the facial nerve travels within the buccal fat tissue plane. Now that we have finished discussing the anatomic structures, we'll next discuss the steps involved in repairing angle fracture. General steps with the repair is that you're going to first start out by exposing all the fracture sites. In particular to the angle fracture site, you're going to be using intraoral incision to expose the angle fracture. It's important to dissect until the posterior border and the inferior border is reached within the subperiosteal tissue plane. The step after that is to perform maxillomandibular fixation to restore patient's premorbid occlusion. This begins the reduction process. Once MMF has been applied, you will then focus on reducing the fracture segment further before applying hardware. To apply hardware in the angle area, transbuccal approach is typically required. Applying hardware at the angle fracture is done only after parasymphysis and the body fractures are repaired first, because angle fracture is harder to visualize and makes it more difficult to repair. Next, I'll discuss some of the surgical pearls that will increase your surgical efficiency. When you look at these two incisions, they look very similar, but there's a big difference in helping you with fracture exposure. First, when you look at the inferior aspect, you'll note that the incision on the right has a wider mucosal cuff. And second, as you extend the incision superiorly, the incision on the left curves immediately, while the incision on the right curves out laterally. This again will lead to left side incision to have a narrower mucosal cuff, while on the right side will have a much wider mucosal cuff. While having wider mucosal cuff is ideal for mucosal closure, it actually makes it much more difficult for plate and screw placement because the excess mucosa will overhang and block visualization of the underlying plate and screw placement. So my preference is to have a mucosal cuff that's about 2 to 3 millimeters lateral to the teeth and minimize excess mucosal overhang that may interfere with hardware placement. To place hardware, transbuccal approach is commonly required in the angle region. When you make the incision, you want to make it parallel to the direction of the facial nerve and center the incision in the middle of the fracture where you expect to place hardware. Once you have created a tunnel that connects a skin incision down to the subperiosteal tissue plane, you have two types of cheek retractors you can use. It actually makes a huge difference which cheek retractor you use for the hardware placement, because your working space will be limited by the masseter muscle and then lateral border of the mandible, and you have about 1 centimeter space to work with. The main difference between these two cheek retractor is a distance from the end of the cheek retractor to the tip of the instrument, as shown as the navy blue arrows. You can see that this straight cheek retractor has a shorter distance. As a result, straight cheek retractor has a much better maneuverability when performing hardware placement within a confined space. As a result, straight cheek retractor is my preferred option. When you look at the transbuccal trocar, you can see this groove. The point of this groove is for you to see drill and screw during hardware placement. So this groove should be pointing up towards you so that it can be seen through the intraoral incision. Another thing to point out is that the cheek retractor should be placed immediately adjacent to the groove. Further you move away from the viewing window, you're going to lose maneuverability because you're increasing the distance from the tip of the instrument to the cheek retractor. Next, we'll discuss various plate configuration. For angle fracture, which plate is more important, superior or inferior? Superior plate is much more important in the angle area. If you have a loading force at the incisor, this will lead to splaying of the superior border of the mandible at the angle, while the inferior border will compress towards each other. This biomechanical property of the angle fracture must be kept in mind when selecting proper plate configuration. A choppy plate refers to using either a 4-hole or a 6-hole plate along the oblique line to stabilize the angle fracture by placing a single superior border plate. A single plate is not as stable as an application of 2 plates in this region. So as a result, I'll only use choppy plate in patients who seem very compliant with 6 weeks of soft diet. Another option is to place 2 plates along the lateral border of the mandible. My preference is to plate the inferior border plate first because the superior border plate is easier to see and easier to plate, but it will also block visualization of the inferior border plate. So I'll generally do the inferior border plate first if it's possible. Because it's hard to place 2 separate plates, I have since modified my technique to use a ladder plate with a 6-hole plate on top and a 4-hole plate on the bottom. This offers increased stability than using two separate plates because the plates are fused to each other. A challenging thing about using a ladder plate is that it's hard to visualize the anterior inferiormost screw hole. You can ensure that the plate is sitting over on top of the bone by palpating with a right angle through the screw hole to ensure that there's bone underneath the inferior anteriormost screw hole. Since superior screws are easier to see, I'll start out with superior screw to stabilize a fracture by placing one screw on either side, and then focus on placing all the inferior screws, and then come back to finish the superior screws. As with other cases, I'll only use locking screws to compensate for the plate offset from the bone. Once I'm done plating, I'll remove maxillomandibular fixation in vast majority of patients unless they have ongoing instability or needs elastic maxillomandibular fixation for concurrent subcondylar fracture. Next, close the intraoral incision in a watertight fashion using absorbable sutures, typically 3 or Vicryl. I'll also use Thermobond to provide additional layer of water tightness. If you hit mucosal tears that makes closure difficult, you can loop the suture around the tooth medially, then loop back to provide additional support to the incision and prevent dehiscence. Thank you for watching.